Hello and good evening, everyone. So, how are you all doing? I hope all of you are fine and doing great. So, welcome to another live session on Eden 2. As you all know, like we are continuing with our general pathology live classes. We had already discussed the basics of general pathology, like the cell in health and disease, the inflammation, immunity, and hypersensitivity, and about healing and all. Now, today we are going to discuss two very important topics. One is fluid and hemodynamic disorders, and the other one is diseases of blood and lymph nodes. Okay, so these two topics are really important because if you look at the previous question papers of NEET MDS or whether it is INICT, definitely you can expect like a minimum of one question from these two topics. Okay, even if you look at the recent NEET MDS 2025 examination also, there were like a minimum of like 4 to 5 questions from these two topics alone. You know that the total weightage of general pathology is like an average of 6 to 8 questions. Out of that, like 4 to 5 questions from these two topics alone. Okay, so that shows how much important these topics are, right? So, like there were questions on like what is an atherotic plaque, and there was a question on the immunohistochemical markers of lymphoma, and there were questions on leukemia. There was a question on hemophilia a clinical based question on a boy suffering from hemophilia A, and about heart failure cells, and all those questions were there. Okay, so that shows like how much exam importance these topics are given by the examiners also. Okay, so if you are someone who is preparing for the NEET MDS exam or the INICT or the upcoming INICT exam, then please make sure that you don't miss these two topics from general pathology. Okay, these two are like really, really important topic. Okay, so without like wasting much time, let's get on to the topic. So in today's session, I have included all patterns of questions. Okay, there are like direct, straightforward one-liner questions like this. And I had also included the clinical based questions, lots of clinical based questions and image based questions also. Okay, so that you get an idea about the pattern of questions that can be asked in the NEET exams. Okay. Okay, so let's begin, doctors. First question, the most common site of arterial thrombus is it coronary artery or cerebral artery or femoral artery or iliac artery? Now, in these two chapters, there are like lots of new terms that you have to study. There are terms like thrombus and thrombosis, emboli and embolism, then shock, edema, then infarct, infarction. Yes, there are lots of terms like this. So let's have a look at it. Yes, doctors. Okay, so we will be discussing all those along with the questions. Okay, all these new terms we'll be discussing along with the question when we come to the question. Okay, so this first question is about the arterial thrombus. Okay, and the most common site of arterial thrombus. What is it? Okay, so yes, doctor. Yes, Dr. Madhu. Okay. So let's have a look at what the arterial thrombus is. Okay, so what you mean by the term thrombus or thrombosis and what you mean by the term thrombus, let's have a look at it first. Okay, so in a thrombosis is a process of formation of a solid mass in the circulation from the constituents of blood. Okay, so imagine if this is a blood vessel. Okay, so this is a blood vessel and blood is continuously flowing inside it. And some kind of changes are happening in that flowing blood. So because of that, what is happening is that a mass, or you can call it like a solid mass can be formed inside this blood vessel, which can block, which can entirely block the blood flow of blood, or may allow some blood to pass through. Okay. So such a solid mass that is formed inside the blood vessel, which can obstruct the flow of the blood, is called as this thrombosis. Okay, that process is called thrombosis. And the solid mass that is formed inside the blood vessel, that is called as thrombus. Okay. Okay, so it is specifically mentioned that this thrombus is made from the constituents of the flowing blood, that is from the plasma and the cells that are present in the blood. From that only this thrombus is getting formed. Okay, so let's look at the pathogenesis of this thrombosis, or pathogenesis of this thrombus formation, how this thrombus is formed inside the blood vessels. Okay, so for that, first you have to know about Virchow's triad. Okay, so Virchow had given three like constituents which are responsible for the formation of this thrombus. Okay, so the Virchow's triad include, first one is endothelial injury, second one is abnormal blood flow, third one is hypercoagulability. Okay, so this Virchow's triad is also important because it is asked in so many competitive examinations, like all of the following are included under Virchow's triad, except, like that question can be asked. Okay, so this is about the Virchow's triad, which is responsible for the thrombus formation. So the first one is endothelial injury, which is the main culprit for the formation of thrombus. And second one is the abnormal blood flow, and then the hypercoagulability. In endothelial injury, what is happening is that typical figure is given here. You can see that there is a breakage between the endothelial cells. So because of that, what is happening is that the subendothelial connective tissue. Okay, so these are the cells, and there you underneath you have the connective tissue also. So the subendothelial connective tissue is getting exposed. Okay, so that will release so many like factors like chemokines and all those chemical mediators, all those will be released into the blood vessel. So that can result in lots of platelet getting aggregated at this site and lots of fibrin getting aggregated at this site. That will finally result in the formation of a thrombus like this. Okay, so that is about endothelial injury. The injury to the blood vessel, that is making the subendothelial connective tissue getting exposed, and it is releasing so many cytokines and chemokines. So that is making lots of like platelets getting aggregated and fibrin getting aggregated at the site. That will result in thrombosis. The next is the abnormal blood flow. Okay, so in this abnormal blood flow, we are mainly focusing on two things. One is turbulence. Okay, turbulence of the blood flow, and another one is the stasis of blood flow. Okay, so this turbulence means like what you can say unequal blood flow. Okay, that is what is called as turbulence. And the stasis means it is the slowing down of the blood flow. Okay, so this turbulence will result in again in the endothelial injury, which again will contribute to the all the other what I had already mentioned, like the subendothelial connective tissue is getting exposed and the factors are released, and it will result in thrombus formation. Okay, so that is about the turbulence. And then next is hypercoagulability. Even in case of like nephrotic syndrome and all, when the the increase in the coagulable factors can result in for example, like in old age and all, in patients suffering from like nephrotic syndrome and all, you can see like increased coagulability of the blood. So that can also result in thrombus contribution. That can also be a contributing factor for this thrombus formation. So here we had discussed about the pathogenesis of thrombus formation. Now let's have a look at the types of thrombi based upon its like origin, where it is seen. Okay, so there is cardiac thrombi, and there which usually arises in the cardiac chambers and in the walls. And then arterial thrombi is there, which usually is seen in the arteries, and venous thrombi, which is usually seen in the veins, and capillary, or the one that is seen in the microcirculation, like capillary thrombi is also seen. Okay, so let's have a look at the difference between the arterial and the venous thrombi. So this arterial thrombi is usually seen in a rapidly flowing blood of other arteries and heart, whereas in the venous thrombi, that is usually seen in slow moving blood in the veins. Okay. Now the site, this is what is common because this is mainly where the question is asked in the MCQ. So the common sites for this arterial thrombi is, it is mainly common in aorta. Okay. And then coronary, cerebral, and iliac and femoral arteries. Okay. So just like it is given here, that is the most common site of the arterial thrombi. Okay. So it is most common in aorta, but since aorta is not given in the question, the next common site is coronary artery. So yes, we had chosen option A as coronary artery. Okay. Now the common site for venous thrombi is the superficial varicose veins and the deep leg veins. And mainly the reason for this arterial thrombi formation is endothelial cell injury, whereas for the venous thrombi, it is venous stasis. Usually they are mural in nature. Most of the arterial thrombi are mural in nature. Mural means they do not completely occlude the blood vessel. Okay, a little bit space will be there for the blood to flow. Okay, it will not be completely occluding in nature. Okay, so that is what is called as mural thrombi. Okay, whereas venous thrombi is usually occlusive, and it just blocks the blood vessel, which will result in ischemia and further infarction and all, which we'll be discussing later. Okay, so if you look at the macroscopical feature, you'll be seeing in the both the macroscopical and microscopical feature, you'll be seeing something called as lines of Zahn like this. Okay, so these lines of Zahn, what do you mean by lines of Zahn means? These are like distinct, like red and white lines that you'll be seeing in the arterial thrombi in both the macroscopy and the microscopical features. Okay. So these lines of sand are mainly formed by platelets and fibrin and the red blood cells. Okay. So these platelets and fibrin, when they accumulate, they will form white lines like this, and the red blood cells, they will form the red lines like this. Okay. So alternating white and red lines can be seen in these lines of sand, which is a characteristic feature of arterial thrombi and which is a characteristic feature of antemortem thrombi also. Okay, so this is one way to differentiate between antemortem thrombi and postmortem clots. Okay, the lines of sand will always be present in a rapidly flowing blood only. Okay, it will not be present in a stasis of blood. Okay, so that's one feature to differentiate between the antemortem thrombi and the postmortem clots. And the effects are mainly, yes, it can lead to ischemia. Like I had already mentioned, can lead to ischemia leading to infarcts, and thromboembolism is usually seen in the venous thrombi. Okay, so we had discussed like the pathogenesis, the virtuous triad about the thrombosis, then the arterial and venous thrombi, and their differences are specifically mentioned here. Okay, so the most common site of this arterial thrombi is actually aorta, but since aorta is not given in the option, we are choosing the next most appropriate option, that is the coronary artery. Okay, then our next question. A 45-year-old male underwent an abdominal surgery and was bedridden for 10 days. He suddenly developed dyspnea and collapsed. He succumbed to death in a few minutes. The most probable diagnosis is, what do you think it is? Is it pulmonary embolism or fat embolism or air embolism or stroke? Yes, doctors, answers, please. Yes. Okay, so the answer is option A, pulmonary embolism. Now, we had already discussed about thrombus and thrombosis. Now, let's have a look at what this embolism and emboli is, or embolus is. Okay, so we know that this is the thrombus. Okay, so the formation of the solid mass in the circulation. Okay, so that is called as thrombus. Now, if a part of this thrombus gets dislodged. Okay, if a part of this thrombus gets dislodged from its initial site and it travels in the circulation and it creates a blockade in the smaller blood vessel in some other part of the body. Okay, so that process is called as embolism, and this transported part, okay, this separated transported part, that is called as the embolus. Okay, so in a thrombus, okay, so to make it easier, in a thrombus a part of it gets dislodged. Okay, so a part of the thrombus gets dislodged and it gets circulated in the blood and it gets dislodged in some other part, okay, in some other part of the body with which has like a smaller diameter blood vessel. Okay, so that will create a blockade in that part of the body. Okay, so that condition is called as embolism, and this transported part is called as embolus. Okay, so I think I had made myself clear. So this is the thrombus and this is the embolus. Okay, now let's have a look at the type of embolus. Okay, so there are like so many divisions of this embolus. Like there is like solid emboli, liquid and gaseous emboli is there. If it is formed from most of the emboli, they are formed as a result of this thrombosis only. Disintegrated part of the thrombosis only had made up this emboli, but it can be formed from fat globules or amniotic fluid or because of air also. Then we have the classification as bland and septic emboli. The bland ones will be sterile and the septic ones will be usually infected. And the emboli can also be differentiated into like paradoxical and retrograde emboli, where in the paradoxical emboli, it means that there will be like the emboli will be carried from the venous side to the arterial side and vice versa, from the arterial side to the venous side also. Okay, so there will be crossing of the emboli. So it is also called as crossed embolus or the paradoxical embolus. Then retrograde embolus. Okay, usually the embolus is getting formed uh, on the direction of the flow of the blood. Okay, but sometimes it can get formed or it can get transported against the flow of the blood. Okay, that is very rare because blood is what is carrying this embolus to in the circulation. But sometimes this embolus can travel against the flow of blood. That is called as retrograde embolus. Okay, then we have the cardiac, arterial, venous, lymphatic, just like what we had discussed in the thrombus. The cardiac ones originating from the atrium and left ventricle, arterial ones that will be usually seen in the main arteries in the brain, spleen, and kidney. Venous ones in the pulmonary arteries, and lymphatic ones in the lymphatic vessels. You will be able to see emboli like this. Now, clinically, there are like important types of embolisms, like pulmonary embolism is there, systemic embolism is there, fat embolism, air embolism, amniotic fluid embolism, atheroembolism, and tumor embolism is there. Okay, so pulmonary embolism is the most common type of embolism and the most fatal type of embolism, in which usually the origin is from the veins of the lower lungs. Okay, and systemic embolism, it's usually arterial in nature from the left ventricle. And in case of trauma to bones or soft tissue, we can see the fat embolism. And in case of like head and neck operations or because of some obstetrical trauma, we can see the air embolism. And because of the components of the amniotic fluid, we'll be able to see amniotic embolism. And because of atheromatous plaques, okay, we'll be able to see atheroembolism. And from the tumor fragments, we'll be able to see tumor embolism like that. Some of the tumor fragments can get dislodged from its initial site and can transport in the circulatory system and can cause embolism in particular sites. Okay, so that will result in tumor embolism. So now let's discuss about this pulmonary thromboembolism. It is, as I had already said, it is the most common and the fatal form of venous thromboembolism. Okay, so what is happening is that usually from the origin is from a thrombus that is originating from the veins of the legs, and it is getting transported and there will be occlusion that is happening in the pulmonary arterial tree. Okay, so the main site will be usually pulmonary arterial tree. And usually the in 95% of the cases, this thrombi will be originating from the large veins of the lower legs. But sometimes it can also get originated from the varicosities of the superficial veins of the legs. Okay, so these are the main causes of this pulmonary embolism. And this type of embolism is very common in hospitalized or bedridden patients. Okay, so if you look at the question, it is mainly seen that the patient has already underwent an abdominal surgery and is bedridden also for 10 days. Okay, so that may be the cause for the thrombus formation in the lower veins of the legs, from where the emboli had transported into the pulmonary arterial tree, and the patient had developed the classical symptoms like dyspnea and had collapsed. Okay, usually sudden death is seen in case of pulmonary embolism. Okay, no signs or symptoms may be seen, just sudden death will be seen. But if it is going slow, then like features of like myocardial infarction. Okay, all the signs and symptoms of myocardial infarction like dyspnea, chest pain, and breathlessness, and all those features can be seen. Okay, so it is a very fatal form of embolism. Now, next question. A patient admitted in the hospital with fracture in his leg bone. In fracture of long bones, which type of emboli is seen? Okay, so we had already discussed just this table is like really important, because that tells you like from what is the cause of this embolism and what you can expect in a clinical situation also. Okay, so the trauma to the bones or the soft tissue mainly causes fat embolism. Okay, so the answer for this question is option A, fat embolism. So let's see what is happening in the fat embolism. There will be obstruction of the small blood vessels like the arterioles and capillaries by the fat globules. Okay, so in case some trauma is happening to the bone or the soft tissues, what happens is that the fat globules will be released from the injured area. Okay, so the fat globules will be released from the injured area. It will go into the venous circulation, and this fat gets accumulated in the small vessels in the lungs, which will create this fat embolism. Okay, not just lungs, it can get accumulated in other organs also, in other major organs also, like the brain, kidney, and skin also. Okay, now this is one cause for fat embolism. Okay, this is the traumatic cause for fat embolism. There are other non-traumatic causes for fat embolism also. Okay, like burns, diabetes mellitus, fatty liver, pancreatitis, sickle cell anemia. Because of that also, this fat embolism can happen. Okay, so if you look at the consequences of this fat embolism, usually it can create in pulmonary fat embolism. Like I had already mentioned, the fat globules will go and get accumulated in the pulmonary tree, which will result in the pulmonary fat embolism. Okay. So usually, if you look at the autopsy picture of any patient who had like a sudden death after the fracture of bones, you can see this pulmonary fat embolism as a common autopsy finding. Okay, in the lungs. Okay, that's a very common autopsy finding that is usually seen. But other than that, not just the lungs, it can also get accumulated in the brain, kidney, and skin also. Okay. Now, next question. Red infarct occurs in. Okay, where will you usually see this red infarct? Is it in heart or kidney or lungs or spleen? Okay, doctors, if you know the answer, you can put it in the chat box. No issues. Even if it is going wrong, no issues. We are all learning here and we are all studying here. So no issues whether it has gone wrong or anything like that. So where will you see this red infarct? Yes. Yes, doctors, you are right. Yes. It is option C, lungs. Okay. So we had discussed about thrombus. We had discussed about emboli. Now we are going to discuss about infarct and what is the process of infarction. Okay, so because of this thrombosis or because of this embolism, the blood flow to a particular tissue or particular organ is getting occluded. Okay, so there will be loss of blood supply and loss of oxygen supply to that particular area. Okay, so that area will undergo ischemic necrosis. Okay, so this localized area of ischemic necrosis that is caused by this occlusion of the vascular supply to the affected tissue, that is called as infarct. Okay, and this process is called as infarction. Okay, so because of this thrombus or because of this emboli, the blood supply to a particular tissue is getting occluded. So that particular tissue will be devoid of oxygen and will be devoid of nutrients and will be devoid of blood supply. So that will create an ischemic necrosis. That will create an area of localized ischemic necrosis in that particular area. Okay, so that particular area is called as infarct, and this particular process is called as infarction. Okay, most of the infarcts are usually caused due to this arterial thrombosis or arterial embolism only. And infarcts can also be divided into like two types. There are red or hemorrhagic infarcts, and there are white or anemic or pale infarcts are also there. Okay. So let's have a look at the difference between this red infarct and the white infarct. Okay, so this is a classical picture of a red infarct, and this is a picture of a white infarct. Okay, so the red infarct is usually caused as a result of venous occlusion. Okay, that's very important. Whereas this white infarct is usually caused as a result of arterial occlusion. Okay. And this red infarct is usually seen in loose tissues. Okay, loose tissues like lungs and small intestine, brain and all, most commonly seen in this loose tissues like lungs, GI tract and brain. Okay, so the blood gets collected in this infarcted tissues like this. That's why it is called as red infarct. Okay, whereas this white infarct is usually seen in solid organs like heart, spleen, kidney and all. Yes, that is where you will be mainly seeing this white infarct. And the tissues with dual circulation like lungs and small intestine, there also you will be seeing this red infarct. And previously congested tissues and flow reestablished after infarction. For example, after like doing angioplasty and all, if the flow is like reestablished, then also you will be able to see red infarct in particular structures. Okay. Whereas white infarct is usually seen in the solid organs like heart, spleen, kidney. And white infarct will be usually wedge-shaped like this. You can see this wedge-shaped pale area. Yes, they will be usually seen as wedge-shaped areas. The occluded vessel will be at the apex and the periphery will be at the base. Okay, so you'll be able to see wedge-shaped areas like this. Okay. Yes. So this is the main difference between the red infarct and the white or pale infarct. So red infarct is usually seen in loose tissues like the lungs. Okay. So the answer is option C, lungs. Now next question, another question that is related to infarct. All are characteristic features of pale infarct except it is found in loose soft tissues. Transient light red color may be present. Involves wedge-shaped area with apex pointing towards arterial obstruction and formed because of arterial occlusion. Okay. So option B, yes, it can be light red in color because in case of like acute infarct cases, pale infarct cases, you'll be able to see like reddish color in the borders that will give a light red color to the infarcted area also. Okay, so transient light red color can be seen in the pale infarct. And yes, we had already discussed wedge-shaped area will be seen with apex pointing towards the arterial obstruction. And it is formed because of arterial occlusion. This pale infarct is formed because of arterial occlusion also. Okay, so the only wrong statement here is it is found in loose soft tissues. No, only red infarct is found in loose soft tissues like the lungs, This white infarct or pale infarct is usually found in solid organs. Okay, solid organs like heart, spleen, kidney and all. Yes, it is present in solid organs. Okay, so the one which is wrong is it is found in loose soft tissues. Okay. Now next question. Warm and flushed skin is usually associated with. Is it associated with cardiogenic shock or hypovolemic shock or septic shock or all of the above? Yes, doctors, if you know the answer, you can put the answer in the chat box. Where will you see such warm and flushed skin? For that, we have to know what this shock is. Okay. Okay, so let's discuss what the shock is. So shock means it is a state in which there is like decreased cardiac output and decreased circulating blood volume. So that will result in decreased tissue perfusion, so leading to overall cellular hypoxia. Okay, so there will be decreased cardiac output and decreased perfusion into the tissues. So that will result in like decreased oxygen supply to the particular tissues. Okay, so that will result in a generalized state of body, which is called as shock. Okay, so clinically, three types of shock are major types. One is cardiogenic shock, and the second one is hypovolemic shock, and the third one is septic shock. Okay, so in the cardiogenic shock, it will be usually due to some defects in the heart, like because of the deficiency of the filling or the emptying mechanism, or because of the some kind of obstruction in the outflow. Because of that only this cardiogenic shock is happening. The next one is the hypovolemic shock, which is commonly seen in case of a hemorrhage, like lots of blood and fluid is lost from your body in case of like trauma or in case of surgery or because of burns or dehydration. Okay, lots of fluid is lost from your body, so that can result in hypovolemic shock. And septic shock is mainly caused as a result of septicemia from gram positive or gram negative bacteria. Okay, usually the ones that is causing this septic shock are gram negative bacteria, but you can see it with the gram positive bacteria also. Okay, so because of all these things that are leading, it will lead to decreased cardiac output, and it will lead to decreased blood flow, decreased supply of oxygen to particular organs, which will result in anoxia. Okay, less oxygen supply, which will lead to increased secretion of inflammatory mediators, which will lead to the specific type of shock. Okay, so these are the major three types of shock and the mechanism that is happening behind it. Okay, and if you look at the stages of shock, okay, the stages of shock can be divided into three stages mainly. We have the initial non-progressive stage, then the progressive stage, and the irreversible stage. Okay, so if you look at this initial stage or the non-progressive stage, two events are mainly happening in this non-progressive stage. One is widespread vasoconstriction, that is blood vessels are getting constricted, and there is fluid reservation by the kidney also. Okay, so in case of like hypovolemic shock and cardiogenic shock, okay, this mainly I'll be discussing about this hypovolemic shock and the cardiogenic shock. So in hypovolemic shock and cardiogenic shock, what is happening is that the body had noticed that because of the loss of fluid only, such kind of the body is going into shock. Okay, so as a protective mechanism, what the body is trying to do is that it will try to constrict the blood vessels, okay, to reduce this fluid loss or to reduce this to compensate for the low cardiac output. What it is doing is that it is constricting the blood vessels. Okay, and the next mechanism is by fluid conservation by kidney also. Okay, so once these blood vessels are getting constricted, it will result is that it will lead to increased peripheral resistance and increased heart rate and increased BP and all. Okay, so that is what is responsible for the cool, clammy skin that you will be seeing in hypovolemic and cardiogenic shock. Okay, so if you look at the clinical features of this hypovolemic and cardiogenic shock patients, you will be able to feel like cool, clammy skin for these patients. Okay, why this full clammy skin? Because there was at the initial stage, there was this widespread vasoconstriction that is happening. So because of that, there will be increased peripheral resistance, increased heart rate and BP. So that is responsible for this full clammy skin. But in septic shock alone, there will be a different mechanism. Okay, so that is what is like making the septic shock stand apart from the other types. Okay, so in septic shock alone, there will be a different mechanism. What is happening in septic shock is that there will be initially there will be vasodilatation. Okay, in the other types, initially there will be vasoconstriction, but in septic shock alone, there will be initially vasodilatation. There will be dilatation of the blood vessels that is happening. Okay, so that's why in septic shock alone, patients will have warm and flushed type of skin. Okay, so you should remember this. In cardiogenic and the hypovolemic types, usually vasoconstriction is happening. That's why they have the full clammy pale skin. Whereas in septic shock alone, they will be having a warm and flushed type of skin because initially vasodilatation is happening. That is dilatation of the blood vessels is happening. Okay, that's responsible for this warm and flushed type of skin. Okay. So next question, orodes are numerous in which subtype of acute myeloid leukemia? Is it AML with erythroid maturation or AML with myelomonocytic maturation or acute promyelocytic leukemia or AML with multilineage dysplasia? Okay, so for this, we have to know about the WBC neoplasms, the leukemias, the different types of leukemias, and the classification of AML also. Okay, and then about the orodes. What are these orodes and where it will be seen, how it will be seen, what is the appearance of these orodes under the microscopy, all that you have to know. Okay, so these orodes are usually seen in, let's see where it is seen. So this WBC neoplasm or the white blood cell neoplasms can be divided into three types. We have the lymphoid neoplasms, which include Hodgkin's lymphoma and non-Hodgkin's lymphoma and all the lymphoid neoplasms are there. Then we have the myeloid neoplasm and the histiocytic neoplasm. So this histiocytic neoplasm include the Langerhans cell histiocytosis and all the other types. So this myeloid neoplasm itself can be divided into three types. We have the acute myeloid leukemia, then myeloproliferative neoplasms, and the myelodysplastic syndromes. Okay, so this is the main classification of this myeloid neoplasm. Now, among this, if you look at this acute myeloid leukemia, there is a FAB classification for this acute myeloid leukemias. FAB classification means French, American, and British classification. Okay, for this AML. So they had classified this AML into 8 types, starting from M0 till M7. Okay, so this M0 to M2 is AML without any maturation. Okay, the minimally differentiated AML, starting from M0 to M2. And M3 is the acute promyelocytic leukemia. M4 is the myelomonocytic leukemia. M5 is the monocytic leukemia, and M6 is the erythroleukemia, and M7 is the megakaryocytic leukemia. Okay. Try to remember the names because sometimes questions can be asked such deeply also. Okay. So in which type you'll be able to see the orodes? You'll be seeing the orodes mainly in the M3. Okay. In M2 and M1 also, sometimes they can be present, but not always. Okay, so we are ruling out the M1 and M2 options. So it is usually mainly seen in M3 only, where you'll be able to see the hypergranular promyelocytes, and along with that, multiple orodes can also be seen. Now let's see what these orodes are. Okay, so you see this red stained rod-like structures in the cells. Yes, these are the orodes. Okay, so this is a classical blood smear picture. Like small rod like red color stained structures like this. Yes, Those are orodes. Okay, they are present in the neoplastic myeloblast, and they are like a hallmark feature of this AML. Mainly, if you look at the composition of these orodes, they are mainly made up of eosinophilic granules. Okay. So this is about the orodes, and they are mainly seen in the M3. Okay, so the answer is acute promyelocytic leukemia or M3 type of AML. The next question. The following image shows a distinct type of cell. Okay, the cell that is marked by this arrow. Okay, so this following image shows a distinct type of cell. Such cells are seen in which type of leukemia? Is it AML or CML or myelodysplastic syndrome or CLL? Where will you see such cells? These cells that are those are marked by arrows. So if you look at these cells closely, you can see that there is no specific like membrane for this cell. The membrane is not there, and there is no nucleus, and the cell itself is not clear. It is more like a smudged appearance. Okay, so such type of cells are called as smudge cells, or they are also called as basket cells. Okay, so these cells, how they are formed in peripheral blood smear is that since the cell membrane of the WBCs may not be that strong, so what happens is that there will be like remnants of this WBC that they during the peripheral blood smear formation, what happens is that they can get partially destroyed. Okay, so they can get partially destroyed and forms smudge cells like this. Okay, so these are the smudge cells like this. And these cells, they lack the cell membrane and they don't have the nuclei also. They typically have the smudged appearance under the microscope. Okay, it will be easy to identify them because these cells, they are called as smudge cells. And these smudge cells are a characteristic feature of chronic lymphocytic leukemia. Okay, so this chronic lymphocytic leukemia means when the peripheral blood lymphocyte count is going greater than 5,000 cells per microliter, then we call it as chronic lymphocytic leukemia. It is one of the most common leukemias in the Western world. And in this type of leukemia, if you look at the general behavior of this type of leukemia, the cells in the tumor cells are giving more importance for its survival than for its proliferation. Okay, so they try to survive somehow, these tumor cells. Okay, so they in those cells, if you look at the immunohistochemistry, you will be able to see lots of high levels of BCL2. Okay, so BCL2 are what to say, like the ones which regulate the which inhibits the apoptosis. Okay, so this BCL2 are the ones which inhibits the apoptosis. So such high levels of BCL2 will be present in this chronic lymphocytic leukemia. Okay, it is a neoplasm of mature B cells, and if you look at the peripheral blood smear, you will be able to see lots of small lymphocytes like this. Okay, they'll be like very dark round nuclei and scan nucleoplasm. Okay, lots of lymphocytes like this will be present because they are the tumor cells. Okay, and definitely they will show all the features of the tumor cells like dark round nuclei and very small cytoplasm, and all the typical features will be seen. Okay, and in between these lymphocytes, you will be able to see smudge cells like this, and proliferation centers will also be seen. Okay, proliferation centers means there'll be particular accumulation of these lymphocytes, which are the characteristic feature of CLL. Okay, so proliferation centers are one of the characteristic feature of CLL along with these smudge cells. Okay, smudge cells can be seen in other pathologies also, but among the leukemias, this smudge cell is usually seen in CLL only. Now, next question. Which of the following statement about hereditary spherocytosis is or are correct? So, which of the following statement is correct? Is this an autosomal recessive disorder caused by defect in protein, which is caused by defect in spectrin, ankyrin, and BAN3 protein? or it is associated with spherocytes, which are smaller and more dense than the normal red cells and have a decreased surface to volume ratio. So, which of the following statement do you think is correct? Yes, doctors, if you have answers, you can share in the chat box. So, spherocytosis. Okay, the one that is caused due to defect in the cell shape of the RBCs. Okay, so RBCs, they usually have a biconcave shape. Okay, so this biconcave shape is will allow these RBCs for more inclusion of hemoglobin, and it will allow for easy passage of these RBCs through blood vessels also. Okay, that's why this biconcave shape is usually given to the RBCs. But sometimes what happens is that because of some defects in the cell membrane in the RBCs, what can happen is that this biconcave shape can be lost and they will be like a sphere. Okay, they'll be just like a sphere. Okay, so such a condition is called as spherocytosis. Okay, so let's have a look at the spherocytosis in detail. So this is the biconcave shape of the RBCs of a normal RBC. A normal RBC will be definitely biconcave shape like this. So if you look at the cell membrane structure of this RBC, you will be able to see the lipid bilayer, and there will be special proteins. Okay, so proteins that are present is, one is this BAN3 protein, and then you have the ankyrin protein, and then at the underlying area you will have the spectrin also. Okay, so in most of the cases of the spherocytosis or the hereditary spherocytosis, you'll be able to see spectrin deficiency. Okay, some kind of deficiency in this spectrin protein will be definitely there. Okay, because of that only this biconcave shape is lost and the RBC is getting into a shape of a sphere. Okay, and along with that spectrin, in some other cases, usually there will be ankyrin deficiency also. Ankyrin is the protein that is binding between this BAN3 and the spectrin. So there will be deficiencies in ankyrin and this BAN3 protein also. Okay, so because of these three proteins only, there will is the main pathogenesis behind formation of spherocytes. Okay, so these spherocytes will be like very hyperchromatic like this, and it will be difficult for these spherocytes to go into the spleens. Okay, it will be very difficult for these spherocytes to go into small blood vessels. Okay, they will not be able to squeeze inside small blood vessels just like the biconcave shape. Okay, so most of them can get destroyed in the spleen, which can lead to splenomegaly. And since most of the most of the RBCs are getting destroyed inside the spleen, what is happening is that anemia can also be seen in such patients. Okay, anemia, splenomegaly can be seen because spleen is getting more and more work because of the destruction of these RBCs. So splenomegaly can be seen, jaundice can be seen, the gallstones can also be seen in this spherocytosis. Okay, so if you look at the peripheral blood smear, you'll be able to see this is how a normal red cell will look like. A pale, somewhat pale in appearance. But spherocytes, they'll be like typically very reddish in color, and they'll be like perfect round or perfect round in peripheral blood smear structures also. Okay, and lots of reticulocytes can be seen because to compensate for anemia. Okay, to compensate for anemia, the immature blood cells, it will be seen in the peripheral blood smear, and osmotic fragility is also increased. If you do the osmotic fragility test with a low salt concentration liquid, these kind of blood cells, they will be easily destroyed. Okay, so that will create a higher levels of osmotic fragility index also. So among the options that are given here, the first one is that hereditary spherocytosis is an autosomal recessive disorder. No, hereditary spherocytosis is an autosomal dominant disorder. Okay, defects in the same proteins, spectrin, ankyrin, and band3 protein only. And it is associated with spherocytes. Yes, spherocytes are smaller in size and they are more dense. Okay, because they have to contain the available hemoglobin. Okay, so they are more dense than the normal cells and they have a decreased surface to volume ratio also. Okay, so the one that is not correct or wrong among the given statement is this option 1. Option 2 and 3 are right. Okay. Now, next question. Which of the following is correctly matched with the forms of extravasation hemorrhages? Okay. So, for that, you have to know what hemorrhage is, what do you mean by ecchymosis, what do you mean by purpura, what do you mean by petechiae, all that you have to know. Okay. So, let's have a look at this. So, hemorrhage means escape of blood from the blood vessels. Okay. So, when the blood is getting escaped from the blood vessels and it is going into the extravascular tissues, it is known as hemorrhage. Okay. So this type of extravasation hemorrhage based upon its clinical appearance. Okay. It is divided into many types like hematoma is there, ecchymosis is there, purpura is there, petechiae is there. Okay. You should know the differences between each term. Okay. Because each term is really important and you should know the differences between each term too. So the extravasation of the blood into tissues with a resultant swelling like this. Okay, so this is called as hematoma. All the types that are given here, hematoma, ecchymosis, purpura, and petechiae are all they all result due to this extravasation of blood only. But based upon their size and appearance only, they are given different names. Okay, so this extravasation of blood into tissues with resultant swelling like this. Okay, so this is called as hematoma. And then large extravasation of blood into skin and mucous membrane and which gives an appearance like this. This is called as ecchymosis. Now, if the area of hemorrhage is a little bit small in size, like up to 1 centimeter only, and it is seen in the skin and mucous membrane like this, then this is called as purpura. Very minute pinhead-sized hemorrhages are seen, then it is called as petechiae. Okay, so the petechiae is the smallest one. Minute pinhead-sized hemorrhages like this will be seen. A little bit larger one, like up to 1 centimeter diameter, then it is called as purpura. More than that, if it is a little bit more large extravasation of blood into skin and mucous membrane, then it is called as ecchymosis. And if it is causing a swelling like this, then it is called as hematoma. Okay, so these are the different types of extravasation hemorrhages. Okay, the names, you should not get confused with these names. These are really important. Now, next question. A lady in the second trimester of pregnancy underwent a hemogram and her hemoglobin was found to be 6 gram per dl. The gynecologist suggested IV transfusion of packed red cells to improve the levels. How much of iron is absorbed by the transfusion of 2 units of packed red cells? Okay, this is kind of like a calculation-based questions, which is rarely asked nowadays in the general pathology section. But still, I want you to get familiarized with such questions also. Okay, so the hemoglobin count was only 6 gram per day. Okay, so that suggests it is a classic case of iron deficiency anemia. Okay, so during the pregnancy time, the iron intake for the female patients must be must be higher, and if the hemoglobin levels are going beyond like going below 10, then we can suspect a case of iron deficiency anemia. Okay, around 350 mg is required for the fetus and placenta alone. Okay, so the remaining portion only the mother is getting. Okay, so the single unit of packed red cell transfusion is you will get like 200 to 250 mg elemental iron. Okay, so for a single unit of packed cell transfusion, you will be able to get like 200 to 250 mg of elemental iron. So here in the question, they had asked like how much of iron is absorbed by transfusion of 2 units of packed red cells. Okay, so 2 units of packed cells will somewhat get like 400 to 500 mg of iron you'll be getting. Okay, so in the question, the options given, the one that is most close to the given value is option D, 500 mg. So we are going out with 400 mg as the correct answer. Now, because of this iron deficiency in the mother, it can lead to premature delivery of the infants, or the low birth weight infants can also result. Now, how will you calculate like how much iron is required for the patient? Okay, there is a specific formula that is given for calculating like how much iron is required for the patient. You can calculate it by this formula. You can multiply the body weight by 2.3 by 15 minus the value that you get in the patient's hemoglobin levels. That will give a rough idea of how much iron is needed by the patient. Okay, to that particular formula, you can add an extra 500 or 1000 milligram extra for the iron stores also. Okay. So for a single unit, it is 200 to 250 mg of elemental iron. So for 2 units, it will be usually 500 mg of iron. Now, next question. Which factor is increased in iron deficiency anemia? Yes. So, which factor will be increased? So, when we are discussing about anemia, anemia is all like the decrease of the iron levels, decrease of the hemoglobin levels, decrease in the RBC levels, decrease in the blood indices, and all the factors are usually decreased. But one factor alone will be increased in iron deficiency anemia. What do you think that factor is? Yes, doctors, let's have a look at the iron deficiency anemia. Because of the, as I had already mentioned, all the factors will be decreased in the hemoglobin count, decreased in the RBCs level, decreased in the blood indices. You can look at all the blood indices, the MCV, MCH, and MCHC. All the factors will be decreased usually. Okay. And the ferritin levels, that also will be very low. But two factors will be usually increased in iron deficiency anemia. One is the total iron binding capacity. Okay, iron binding capacity will be increased. Okay, so that is considered more like a protective mechanism by the body. Okay, since all the iron stores and iron levels are decreased, this the body try to bind the iron, whichever whatever is present in the body, so that it will, the total iron binding capacity itself is increased. Okay, and the serum transferrin receptor proteins also. Okay, so the transferrin receptor proteins are also increased in case of iron deficiency anemia. Okay, so iron can be stored in the form of like ferritin. Okay, iron can be stored in the form of like ferritin and hemosiderin and all. So the ferritin levels can also be low. Okay, so among the factors that are deficient in the iron deficiency anemia, the serum iron levels will be low, the protoporphyrin levels will be low, the ferritin levels will be low, all these levels will be low, but the total iron binding capacity alone will be increased in case of iron deficiency anemia. Now, next question. A 20-year-old male patient complains of recurrent attacks of sore throat for 2 years. The total leukocyte count was 1000 per microliter and a differential count revealed severe neutropenia. What is the diagnosis? Okay, recurrent attacks of sore throat and the leukocyte count is low. Okay, so the normal leukocyte WBC count is usually like 4000 to 11,000 per microliter, but here look at it, the leukocyte count is like very low, only 1000 is there. Okay, and neutropenia is also there. Okay, so these are all characteristic features of which disease. The first one is leukemia. Okay, subleukemic leukemia. Leukemia will means increase in the number of WBCs. Okay, so that is ruled out. Then infectious mononucleosis. Infection mononucleosis, since it's an infection, you will be able to see like lots of increased amount of lymphocyte, and there will be atypical lymphocytes seen in the peripheral blood smear also. Okay, since nothing of that sort is mentioned, we are ruling out infectious mononucleosis also. Then leukoerythroblastic anemia. Okay, so in this leukoerythroblastic anemia also there will be increased if you look at the blood picture, there'll be increase in the leukocytes. Okay, so the option that is remaining is option C, agranulocytosis. You will be seeing agranulocytosis means like if there is reduction in the number of granulocytes in the blood, then that is if the number is going below like 1000 cells per microliter, then it is called as neutropenia. Okay, so the severe form of neutropenia is called as this agranulocytosis. So in agranulocytosis, sometimes the neutrophil counts can go as less as 500 cells per microliter also. Okay, so it will cause both local symptoms and systemic symptoms like ulcerative lesions in the oral cavity and necrotizing lesions in the gingiva or the floor of the mouth or anywhere in the oral cavity, and agranulocytic angina. Such painful ulcers will be there, and sudden onset of sore throat. These are all characteristic features of this agranulocytosis. And systemic symptoms like malaise, fever, and chills can also be seen. Okay, so when you do a blood picture for this patient, and if you're finding the granulocyte count is very less, like in less than 1000 cells per microliter or less than 500 cells per microliter, then you can definitely suspect a case of neutropenia or agranulocytosis. Okay. Now, next question. A 59-year-old male patient reported with swelling in neck, fever, weight loss, and night sweats for past 6 months. General examination revealed painless lymph node enlargement in the neck, and lymph node biopsy showed proliferation of the lymphocytes with intermittent large cells showing bilobe nucleus with owl-eye appearance. And IHC was also done for this patient. It showed positivity for certain markers. Which of the following markers will be positive for this distinct cell? Okay, so such a similar type of question was asked in the NEET MDS 2025 examination. Like a patient reported with the swelling in the neck region and night sweats and all the other symptoms are given, and lymph node biopsy was taken, and a classical owl eye appearance cell is seen, a nuclei is seen, and IHC was also done for this. Immunohistochemical analysis is what to say, a little bit advanced kind of diagnostic method. Okay, we use specific markers, okay, for identifying specific cells or specific tumors. Okay, if there is a confusion in the histopathological report, then we employ something called as this immunohistochemistry. Okay, so this immunohistochemistry is much more advanced than the just doing the histopathology. It is a much more advanced diagnostic technique in which we use specific markers. Okay, so with the help of these markers, we'll be easily able to identify the specific cell or the specific tumor. Okay, so that's why we use this immunohistochemistry. Now, recently only they had asked these questions related to immunohistochemistry, like which type of markers can be seen. That is a little bit advanced in nature, but still you should know which are the markers that are present for specific type of cell. Okay, so from the symptoms and from the histopathological appearance itself, we had come to know that they were talking about Hodgkin's lymphoma. Okay, because typical nucleus with owl-eye appearance, that is a typical feature of Reed-Sternberg cells. Okay, so these Reed-Sternberg cells are seen in Hodgkin's lymphoma only. Now you have to know like which all markers will be positive for these Reed-Sternberg cells in Hodgkin's lymphoma. Okay, so let's have a look at the different types of lymphomas. You have the Hodgkin's lymphoma and the non-Hodgkin lymphoma. This Hodgkin's lymphoma can again be classified into two. We have the nodular lymphocyte predominant and the classic type. This classic type is again divided into 4 types. Lymphocyte predominant. Okay. Lots of lymphocyte can be seen. Nodular sclerosis, that is in between the lymphocyte, you will be able to see like fibrosed structures can be seen. Mixed cellularity, almost all the cells can be seen, or lymphocyte depletion type. Okay, lymphocyte depletion type means very few lymphocytes are only seen, and this is the most lethal form of Hodgkin's lymphoma. Okay, so this lymphocyte depletion type. Now, the characteristic feature to differentiate between this Hodgkin's lymphoma and this non-Hodgkin lymphoma is the presence of Reed-Sternberg cells. Okay, so these Reed-Sternberg cells will look like this under the microscope. A typical all-eye appearance like this. Okay, so this the nuclei will give a typical all-eye appearance like this. Prominent eosinophilic nucleolus with a clear halo and a bilobed nucleus. Typically, a large cell with a all-eye nucleus like this will be seen in the Hodgkin's lymphoma. Now, this is a classic Reed-Sternberg cell. Okay, so this is a classic Reed-Sternberg cell. Now, there are other variants of these Reed-Sternberg cells also. Let's see what the variants are. You have the polypoid or popcorn cells like this. Okay, so these popcorn cells like this will be usually seen in the lymphocyte predominant type. And then you have the pleomorphic type like this, which have atypical nuclei and which will be usually seen in the lymphocyte depletion type. And you have the lacunar RSL like this. Okay, it will appear as if the cell is sitting in a lacunae. Okay, so that will have a pericellular space like this. So this type of RSL is usually seen in the nodular sclerosis type. Okay, so you should know the variants of Reed-Sternberg cells and where they are seen. Okay, and coming to the histochemical analysis. Okay, so this is a like this is the IHC picture after they had employed the markers. Okay, so this brown colored positivity that shows that this particular cell type is positive for that particular marker that is used. Okay, so the normal IHC markers that will show positivity for these Reed-Sternberg cells are CD15 and CD30. Okay, remember it, CD15 and CD30. 15 2 times. Okay, 15 multiplied by 2 is 30. So remember that the IHC markers that will be positive for this Reed-Sternberg cells are CD15 and CD30. Yes. But in lymphocyte predominance type alone, this CD15 and CD30 will be negative. Only CD20 will be positive. Okay. In the lymphocyte predominance type, we will be able to see popcorn cells or polypoid cells like this. So this popcorn or polypoid cells will show negativity for the CD15 and CD30. For them, it is CD20 alone will be positive. And for nodular lymphocyte predominant type also, CD15 and 30 will be negative, only CD45 will be positive. For all the other variants of the Hodgkin's lymphoma, it will show positivity for CD15 and CD30. Okay, so just remember the markers alone for the Reed-Sternberg cells, it is 15 and 30. 15 multiplied by 2, 30. Okay, so remember like that, 15 and 30 alone. Okay. Next question. A young woman reported with frequent bleeding of tongue, lips, and palate. Minute petechial hemorrhagic spots were also observed. Blood investigation revealed decreased RBC, platelet, and neutrophil count. Reticulocyte is also count is also less than 1%, and bone marrow hypocellularity is also the probable diagnosis will be. Okay, so from the symptoms itself, you can see that, and the investigations itself, you can see that all the components of the blood are reduced. Okay, the RBCs are reduced, platelet and the neutrophil count is reduced, reticulocyte count is also reduced, and bone marrow hypocellularity is also reduced. Okay, almost all the features, almost all the like the investigation values are reduced only. Okay, so that will give an idea about the diagnosis. It is aplastic anemia. Okay, so aplastic anemia is kind of like a pancytopenia. All the cellular elements of the bone marrow will be reduced in nature, whether it is RBCs will be reduced, the WBCs will be reduced, platelets will be reduced, everything will be reduced. And if you look at the bone marrow picture also, you'll be able to see aplasia like this. Very less amount of cells will be seen. Hypocellularity will be seen. Okay, so such type of Pancytopenia is usually seen in aplastic anemia only. This aplastic anemia is of two types. We have the primary type and the secondary type. This primary type includes mainly the congenital type of aplastic anemia. So this congenital type of aplastic anemia is called as Fanconi's anemia. Okay, and it can be immune mediated also. Then the secondary aplastic anemia can be caused due to drugs or because of infection or because of some toxic chemicals. Okay, so congenital one, it is called as Fanconi's anemia. Okay, remember the name. It is called as congenital aplastic anemia is called as Fanconi's anemia. Okay, so if you look at the patient, the clinical features of decreased RBCs will be there, clinical features of decreased WBCs will be there, and clinical features of decreased platelet count will also be there. So anemia, there'll be definitely like weakness and fatigue will be there. And because of decreased platelet count, there will be hemorrhage. Okay, platelets are not there. Okay, so definitely you can expect hemorrhage from skin, nose, and all the other structures will be there. And reduced WBC count can lead that patient, make that patient prone for infections. Okay, mainly the infections of the mouth and throat will be there. Okay, and the other organs will not be enlarged also. Lymph nodes, liver, and spleen will not be enlarged also. No hepatosplenomegaly or nothing will be seen because usually when the spleen or liver is getting they're destroying something or they are making something only, their enlargement is here. But here everything is like reduced, so hepatosplenomegaly is also not observed. Okay, all the other features of the three deficient states, anemia, thrombocytopenia, and leukopenia, will be seen in this aplastic anemia patients. Okay, so I think that's too much pathology for today. If you can have any doubts, then you can ask now or you can put it as a question. If you don't remember, then you can, if you are not feeling any doubts, then you can put it as a question under this video. We will definitely respond to it. Okay, so next class we'll be coming up with the neoplasia and the systemic pathology and other miscellaneous topic and genetics also. Okay, we'll be dealing with genetics also in the next class. So next live class we'll be informing soon. Okay, so thank you so much for attending the session. Keep reading, keep practicing MCQs, and keep revising. Okay, all the best for your preparations. Do well. Goodbye and good night.